So we first got interested in SGRT back in 2013 when we knew that we needed to implement a deep inspiration breath hold technique at the QE. We assessed all the options, the sort of spirometry options, SGRT options, and we decided that SGRT we felt was the best way to implement it. Immediately interested in Vision RT over any of the other companies, and QE Charity, who we're closely associated with, were very interested in actually purchasing the equipment for us. However, this happened. But that was us. Tortoise represents every NHS trust in England, I think, but the crown represents what happens if you just keep on going. So in that 2013 to 2018 period, we had capacity issues, we had linac replacements, ongoing programme for that entire period. So all our prostates were pushed off to a local private centre. We had a contract with them. The trust knew that DIBH took a little bit of extra time, and there was no extra tariff associated with deep inspiration breath hold. And I think we probably all agree that needs to change. It's a lot more resources involved in doing DIBH, so I think that needs to be factored into an NHS tariff. So if anyone has any influence with NHS England, mention that. But in 2018, in June, we went clinical with DIBH, which was what we had to go clinical with first, probably one of the more complex breast techniques with SGRT, but it's why charities funded the equipment, so we had to go live with that. And we immediately noticed an improved accuracy for DIBH based on our EPID results. And when all left-sided breast patients offered DIBH as standard, as agreed with QEHP charities, we then moved to SGRT setups for all of our breast patients. But they still had tattoos, we were just ignoring them. And we also noticed this improved accuracy for this patient group as well. It's just a bit of a summary. You can see the percentage of patients requiring correctional shifts implemented into their shifts from Mosaic. Tattoo, 28.1% of our patients needed some sort of shift during their treatment. DIBH is obviously the best because the patient's not breathing, so they're static. But then SGRT free breathe, also very good reduction in correctional shifts. And also our random errors were reduced in DIBH. Not so much in free breathe, but I've got a bit of a theory about that, so if anybody wants to talk about that, you can catch me later. And also our repeat images were reduced with SGRT. Often you're chasing your tail with some patients, and I think that's because you're setting up sometimes large patients with tattoos that are largely irrelevant. When you actually look at the area you're treating, SGRT reduces that sort of chase your tail scenario. So we moved from tattoo positioning aided by a line RT to purely SGRT setup. So they had tattoos, but we ignored them. And we'd gained a lot of confidence in the system based on what we'd seen. But why would you actually remove tattoos? A lot of people see it as just a tiny little thing that is irrelevant. You're having radiotherapy that cures your cancer, so why would you care about tattoos? But I think there is an argument to say that, and some of these gentlemen would also say that tattoos should not be used. Personally, I'm going to get double-decker on my head for my 40th birthday rather than Kit Kat. But yeah, so tattoos. It's an unsuitable surrogate in my opinion. It's remote from the area you're actually trying to treat, and we see that when we're in CT, where we've bought gate CT, but we haven't got it yet, and you're using tattoos to try and predict what the chest rise is going to do. If you've got large patients, mobile skin, it's remote from the actual area that you're treating. It's largely irrelevant. Skin's a mobile elastic organ. We've already had a talk today on the psychosocial impact on patients, so I don't think anybody would have them, generally speaking, if they could opt not to. But radiographers, because we were still having tattoos and ignoring them, radiographers found it fairly uncomfortable ignoring these tattoos. So as much as you said, ignore them, and then people would come and see what you're doing from other centres, you'd look on the CCTV and the radiographers were still rotating these patients. It was like, just stop using them. So it's there, why wouldn't you use it? But they they are used to it now because we've stopped using them. But because at this point we had DIBH, we had tattoos, we had SGRT patients where we were ignoring tattoos. There was a fair amount of confusion across the department. We've got 75 radiographers there or thereabouts, and they're all rotational, so to try and get them used to what's happening on those two linacs at that point, it was fairly confusing. But we just put a lot of support in place where they wouldn't normally phone the tech leads as much for breast patients. It then became, we need to phone the tech leads, but we put that support in place and a lot of extra training, and it was fine. As we increased the amount of patients that we positioned with SGRT, it became apparent that it was more efficient. So when I was conducting this study, I was trying to time patients. So I'd make a list in the morning of who was SGRT and who was tattoo, so I could go and time people. And you go around at that time, or maybe 5 minutes before, because you want to catch the patient, that they treated them already. So it was already fairly apparent that the room was running ahead of schedule. But accuracy and efficiency, if you're trying to get a business case passed for a line RT or anything, that's exactly what the trust want to hear. So that was in our favour. So I decided to time patients from door to door. So the moment they walked into the bunker to the moment they walked out. And I think that's how the radiographers saw me with my stopwatch. And it soon became clear that although the time spent in the room was interesting and relevant, it wasn't directly related to SGRT positioning. There's lots of elements that happen in that treatment room, long discussions, elderly patients. The patients we're talking about undressing and dressing, and they can talk for ages, and fair enough, they're allowed to. Complex patient checks also impacted on the in-room data, verification processes, superclav patients, if you were trying to time an SGRT patient without a superclav, and then you were timing a tattoo patient with a superclav, and cone beam CTs for our photon boosts. So I decided to adapt what I was looking at and collect a different data from the moment they lie down on the couch to the moment they reach the correct treatment position. So if somebody had a tattoo, that was once we'd done all the mosaic shifts and we'd checked it with a ruler to make sure we'd shifted to the right isocenter position. And if it was SGRT, it was when all your deltas went green. And this, I felt, focused purely on the time it took to actually position the patient. The radiographers, we're a busy department. We've got 300 patients through the door every day. So as much as I'd asked them to do it, they tried, but it was down to me to go and collect the data, really. And that's why the numbers aren't great, but I think it still shows enough. So I decided to time patients who are whole breast only. I excluded photon boosts because they're a lot quicker. But also on imaging days, they have cone beam CT, so that skews the data a little bit. Ignored superclav patients, bolus patients, because it takes a little bit longer with SGRT. You've got to tell the system that you've put the bolus in place and do a surface capture. And any planned image verification fractions, I didn't time that. However, if there were setup issues with either group, I included that. And this is the results, really. You can see there on the left-hand side of the screen, the blue is the tattoo setup and the yellow is the SGRT setup. 40 to 60 seconds, we were setting patients up in less than 60 seconds. Whereas if you can see the blue, it doesn't really kick into your sort of 1 minute 20, 1 minute 40 scenario. So you can see the trend there that SGRT gave us. Hence, when I went around to time the patients, they might have already been treated and left the department. So I think that is clear that SGRT gives us those efficiency gains, which isn't just good for the department and the NHS, it's good for the patient because they're in and out a lot quicker. And the total time spent in the bunker is also directly related to the time that it takes to achieve isocenter position, and that graph shows the same. So I had 30 patients in each group, really, 30, 31. And that's just a bit of a summary. So our quickest patient setup in our SGRT group was 48 seconds. That's from when they lay down on the couch to when we were moving the gantry around to their first treatment position, whereas it was 1 minute 28 for the tattoo. And you can see there that the SGRT on average gave us a saving about 42.5%. And when you look at that as 1 minute 7, you're like, is that? But when you've got 45 breast patients on 2 Linacs a day, that adds up. So I think that's a good saving, really. And a bit of stats. I don't really get it. Using the Welsh's t-test, the probability of setup times are the same for SGRT and tattoo positioning is probability of 0.001. So the time saving comes really from the fact that you're not setting up these largely irrelevant tattoos, then doing your shift from tattoo to isocenter position. You're not wasting time on that, and you're positioning the area we actually want to treat. We all know Vision RT has 10,000 points in the region of interest, and it's looking at the area you're treating, not these kind of arbitrary points on stable anatomy that, especially on larger patients, could be anywhere, and you can spend all that time getting into position, and then when you take a PI, you're miles away. So SGRT rules all that sort of stuff out. The reduction in difficult setups that delay the room and inconvenience the patient was reduced a lot. The indignity for the patient if you'd rolling them all over the place was also reduced. And also for the radiographers, it's a manual handling issue. The couch is up here, the patient's up there. So there's benefits to both patient and staff. And we had some patients who, when we did position with tattoos, when we were still doing some tattoo alignment, some SGRT alignment, we had some patients that you would spend 15, 20 minutes getting into position with their tattoos, and then when you eventually there, you're like, oh, thank God. You leave the room, you take an EPID, and you're miles away. And we had 2 or 3 patients in the early days where we'd then go back to planning and say, can you send us all the DICOM data for the SGRT? And then they were there straight away, and their EPIDs were perfect. So in conclusion, we proved that Align RT was a more accurate setup compared to tattoo positioning. We've now shown that it's more efficient positioning technique as well as more accurate, because there's no point being more efficient if you take a hit on the accuracy. So they go hand in hand. And it directly reduces the time spent in the room for the patient. This efficiency over the course of 2 or 3 Linacs treating breast patients in our department could improve cancer targets. It will improve the access to radiotherapy treatment for patients. And we moved to Markerless for breast radiotherapy just last month in October. We've treated 4 or 5 patients now tattooless. It's been absolutely spot on, perfect. But all the work we'd done running up to that point put us in a position where we felt we could turn it on overnight if we wanted to. And we're hoping to roll it out to all of our breast radiotherapy patients in January, February. What slowed us down is we had 2 Align RT units, but our breast patients were over 3 Linacs, and we didn't want to be in a position where it was like a postcode lottery. If you were on room 2 or 5, it was a Markerless treatment, but if you're on room 7, you had to have tattoos, because these patients have all been in support groups together, they've been in chemotherapy together, and we didn't want any issues with patients being unhappy that they had tattoos, whereas their friends were Markerless. But we've put an order in for a 3rd Align RT, which is hopefully going to be installed soon. So that's let us be confident in starting the rollout early, because we know there won't be any patients who are ruled out of Markerless. So that's it really. I'd like to thank the QEHB charity who purchased the equipment for us. Mark, who's here in the audience, he's our senior physicist at QEHB, who implemented with us and did all the commissioning and all that. Abdul, also in the room, and everybody at the QE, because if you don't have the workforce on board with this fairly dramatic change, then they could kick back and it could fail, but everybody saw how easy it was to use, how intuitive it was, and they've all been on board since day one, so that really, really helps. And of course, Vision RT for making the product. So yeah, thank you.